about a decade or two back. Major surgeries, major laparotomies for almost every case. But now, this is what most of our cases look like nowadays, right? So I am a trained laparoscopic surgeon and I moved to robotic much later. So majority of our cases are still laparoscopic. My caseload is around 70% lap and 30% robot. Most of my cases are like this. So I'll just share a small video with you of how it's not playing. Where's that? Okay. Sorry. Something wrong with this video? Is it playing? Yeah. So at least let me skip the colon part. Let's go to the thorax. I see Professor Palanivelu in the audience. He was probably the first one to publish thoracoscopic esophagectomy in the prone position, and that's what we continue to follow. We do it in semi-prone nowadays, and we have moved to robotic. But laparoscopy gives us so much of advantage. The morbidity has just gone down so significantly. We are able to offer these surgeries to more and more sicker patients, more elderly patients who tolerate these procedures well. This is the extended lymphadenectomy that we are doing, the subcarinal lymph nodes. And you can see it's so beautifully seen. The carina is there, the trachea is there, the bronchus is seen, and you can do extended lymphadenectomies without any problem. The abdominal part, again, you can do it laparoscopically. You can do the two-field lymphadenectomy. This is how we just mobilize it. The vision is so good, the dexterity is there. From lap chole in 1990s to almost every surgery, to HPDs and ripples. Today, laparoscopy has become a standard of care in most of our practices. Now this is dividing the left gastric artery at the root, clearing all the lymph nodes. And so technology has helped us even more. Now we can use things like ICG. This is ICG to confirm the vascularity of the conduit that you have made and to ensure that the tube that you have made is absolutely vascular, and then you can anastomose it. So laparoscopy has definitely brought a lot of change to how we practice oncology now. Next slide, again short video of a spleen preserving distal pancreatectomy, again done laparoscopically. Again, once you have acquired a certain skill set, any of these procedures can be done. Obviously, there is a learning curve, but if you do it constantly and continuously, you will obviously get through that curve and you will be able to do these procedures safely. Now, the morbidity of any procedure is because of two things. One is the procedure itself, and second is the excess that we take. For example, in this distal pancreatectomy, spleen preserving, in a conventional open procedure, I would have done a large midline laparotomy incision or maybe a large subcostal incision with an extension. But if you do it laparoscopically, you can do the same job laparoscopically with very minimal incisions and just a small incision to extract the specimen. So what I'm doing here is I'm just trying to dissect the distal pancreas off the splenic artery and the splenic vein to preserve the spleen. So this is a spleen preserving distal pancreatectomy. We have realized that the benefit of laparoscopy extends beyond. So look at this case. This is a cirrhotic liver, and I have to do a left lateral hepatectomy in this patient. A cirrhotic patient, if you do a left lateral hepatectomy, the chances of decompensation are significant. But if you do it laparoscopically, the literature says the rate of decompensation goes down because you are not violating the abdomen, you are not damaging the collateral circulation. So the benefit of minimal access approach, be it robotic or be it laparoscopic, goes beyond what we see on table. Again, a TAMIS approach, this we do it quite often when we have large polyps or polypoidal tumors in the rectum. You can do these platforms called, this is a gel point path, you can do an excision and a repair there. Now, this is what many of our cases now look like. So we have also migrated to robotics, Like Dr. Dawaz said, it gives you an added advantage of the stability, longer arms, extended freedom of movement, and it definitely helps you in difficult cases, morbidly obese patients, low-lying tumors in the rectum, those difficult locations. A complex procedure like a Whipple would be much easier robotically than laparoscopically, I must say. So just a small video to show you a bottom-up approach of a right hemicolectomy. Now in this approach what we use is something called as a bikini incisions. So we put ports below the waistline, so if there's a young lady who wants to get a surgery without absolutely any scar on the visible abdomen, you can use the robotic to put all the ports below the waistline and do this procedure. Specimen extraction will be done through the phalansteal incision. So robot does allow us these kind of procedures to be done, and this is definitely a boon not only to the surgeon. I mean, operating on a robot is definitely a comfort for a surgeon. You do a 6-hour laparoscopic procedure, your hands will ache, your shoulders will go frozen. You're doing it robotically, you can walk out after 10 minutes if you're feeling exhausted, you can stretch your arms and you can sit back on the console and operate. It's absolutely a blessing. So, and this definitely helps. So this is a complete mesocolic excision with a D2 dissection for a right colon done robotically. So I will spare you of this video. I think it's too much, too many robotic videos that we have had. Dawaz, like I said, has done my job easier by showing wonderful ripples robotically. When we practice oncology, the oncology goes beyond surgery. I think the oration Professor Harit gave in the morning is basically says that if medicine were a sport, oncology is the ultimate team game. So a surgeon alone can do only little. You have to rely on your medical colleagues, you have to rely on your radiation colleagues, you have to rely on so many other people to help you out. So just the chemotherapy and radiation has become a standard of care in most of the cancers now. Neoadjuvant protocols are standard. More than 80% of rectum and esophagus and stomach now receive neoadjuvant therapies before they go on for surgery. Adjuvant therapy is required in almost 80% of cases in most GI cancers. What is emerging now is the role of immunotherapy. I'm not saying immunotherapy is a standard now, but it is an emerging role and it has helped us in difficult scenarios. So just give you an example of this case. We did an extended right hemicolectomy with a D2 dissection for a CA colon. It was a T3N2 disease. This patient has an early recurrence. Now this tumor was an MSI high tumor. Very lucky for the patient, but unfortunately MSI high tumors are chemo-resistant tumors. So this patient was treated with Pembro, and this is the response that you get. Sometimes these responses can be magical. This is the way forward. I mean, the technology, the advances that is happening in oncology is beyond just surgery. So I thought of sharing it with you since you guys may not be doing it in day-to-day practice every day. Again, immunotherapy, again an emerging role. This gentleman is a colleague of ours, he's a surgeon himself, detected to have a CA gallbladder, unfortunately locally advanced stage to begin with, large lymph nodes infiltrating the head of the pancreas. He was treated with neoadjuvant therapy. Now there is no data to add neoadjuvant therapy, immunotherapy in CA gallbladder, but the people who treat lung cancers routinely, they know that the role of neoadjuvant immunotherapy in lung has become standard now. This patient was treated with neoadjuvant chemo and immuno. He had a wonderful response, and then we went ahead and did surgery. So these therapies are allowing us to offer the curative surgeries to these patients which initially were not possible. And as we know, till today, surgery remains the only potentially curative treatment for most solid organ cancers. Again, surgery for stage 4 cancers, cytoreductive surgeries and HIPEC. This is one of the areas which we focus a lot on. We have one of the high volume centers for cytoreductive surgeries, and this is a case of appendiceal tumor with disease spread out onto the peritoneum. So this patient underwent a cytoreductive surgery with complete cytoreduction and a HIPEC. So what we use in HIPEC now is a mitomycin C, which was given hypothermically intraperitoneally, and this technique has a potential to cure a lot of tumors, including appendiceal tumors, highly selected colorectal tumors, a lot of ovarian cancers, and in some cases of gastric cancers. And we are offering these therapies regularly to our patients now. Obviously, expertise, high-end critical care, and also a good case selection is required when you subject these patients to these kind of therapies. This is PIPEC. We use this. This is a pressurized intraperitoneal chemotherapy infusion used in highly selected cases where we give pressurized chemotherapy inside the peritoneum. Indications are far and few. Taxane-resistant ovarian cancers or intractable ascites. This is where we use these therapies nowadays for. Metastatectomies and extended liver resection for colorectal liver metastasis and neuroendocrine tumors. They are again standard of care in most of the colorectal centers. Metastatic sarcomas, we are using cytoreductive surgeries and HIPEC even for these cases. One of the things that is very important is a high-end critical care unit which has to be associated with you and a good perioperative support. We are able to offer surgeries to now sicker and the sickest of the patients. Now this is a child, 5-year-old of rhabdomyosarcoma. He was on ventilator, we operated, he got chemo, he got radiation, and guy was healthy thereafter. We could do this because we have the kind of support that we require. We have the most expert critical care team, we have the dedicated ICUs with us. Again, one of my favorite slides. These all ladies and gentlemen are more than 90 years and they have all undergone major cancer surgeries. We are able to offer these surgeries to these people because the kind of team we have and the kind of team we intend to build. Sometimes surgery is not the option, then we have to resort to other things. A chain is as strong as the weakest link, so you have to make every link strong. Now, we are lucky to have an expert intervention radiologist and a very good theranostic department with us. We can offer the most difficult procedures, the TARE, the TACEs, the RFAs to all of the tumors that are required. Now, the cornerstone of any good oncology unit is this. It is the team and the talk. The team has to be there, which has to work single-mindedly for the benefit of your patient. Everyone should sit down on the table to discuss each case, and this has to be built in the culture. And I cannot thank Dr. Chaturvedi more. He has ingrained this culture in our unit that every case has to be discussed in the tumor board. Every specialist, if you look at this picture, we have a pathologist, we have a radiologist, we have the surgeons, we have a med-onc, we have the radiation onc. Everybody, the attendance is mandatory. You can't skip this meeting. And when you do this with patient care in mind, you definitely get good results. And these are the people I have to acknowledge because much of the work that I shared were due to them. Thank you so much for your patient hearing. I'm happy to take any call. Thank you, Dr. Sorry? Oh, partners in crime. Just a fun slide, that's all.
Okay.
Because they are my partners and it's surgeries in crime.
Respecting and acknowledging the colleagues is a good surgeon's sign. That's good. Thank you very much.
Thank you.
A token of appreciation to the esteemed speakers of this lesson, for which I'd like to invite the chairpersons on the stage to present the speakers with the certificate and the token of appreciation. Please walk up on the stage. Aditya Kumar sir. Surendra Kumar Davas sir.
Thank you, Sumit.
I'd like Bhattachan sir and Kamal Koirala sir. C.L. Bhattachan sir. With that, I announce the conclusion.
Good afternoon. Dr. C. Pallinivelu, a man who needs no introduction. It is an honor to introduce him today. Fondly regarded as Chief Sir, he is an extraordinary personality, not just because of his accomplishments, but the extraordinary journey that he went through, an inspiring story of bravery and determination. His biography, Guts, which will be releasing soon, and fortunately I had the opportunity to have it. As a renowned gastrosurgeon, Dr. C. Pallinivelu has significantly contributed to the field of medicine. His surgical skills and innovative techniques have not only benefited his patients directly, but have also influenced the broader medical community. Dr. Pallinivelu sir's list of accomplishments is extensive and reflects his dedication to the betterment of healthcare. His revolutionary technique for esophagectomy, aptly named Pallinivelu technique, has become a hallmark in the field of cancer treatment. His pioneering method reflects his commitment to improving patient outcomes and minimizes the invasiveness of surgical procedures. Dr. Pallinivelu achieved a historic milestone by being the first surgeon in the world to perform the laparoscopic Whipple operation for cancer of the pancreas. That feat not only showcased his surgical expertise but also opened new possibilities for minimal invasive pancreatic surgery globally. His prowess extends to integrate procedures such as laparoscopic excision of cysts, hepaticogenostomies, and his innovative Pallinivelu additive Tokar systems. His groundbreaking work in SILS was recognized and earned him the prestigious SAGES Award. His innovative approach exemplifies his commitment to pushing the boundaries of minimal invasive surgery. His expertise in gastrectomy for stomach cancer was underscored by his keynote address at the Japanese Society in 2006, and he received prestigious Lifetime Achievement Award by the Royal College of Surgeons of Edinburgh, UK, in appreciation of his profound scientific contribution in the field of MIS globally. He was also bestowed upon the BC Roy National Award in 2006, and he made history by becoming the first Indian to win the Indian International Olympic Silver Medal for Surgery in 2009 at the SAGES. His awards and recognitions, spanning from national honors to global accolades, underscore his profound impact on the medical community and stand as a testament to his unparalleled legacy as a surgical pioneer. So it is indeed an honor for me to invite him for Professor Andani Kumar Sarma today. So I had the opportunity to meet him first at 2008, and after 15 years, I'm fortunate enough to have him at Kathmandu today. Thanks.
Giving this great honor of presenting Professor A.K. Sharma oration. Dear surgeons, President Sunil and council members, office bearers coming from Bangladesh, Sri Lanka, Pakistan, and SAARC countries. And I'm happy to take this today, coming to Nepal first time, and I'm delighted and seeing my old friends here. They're also coming first time. Looks as though I've been in many times. I've been to Kathmandu Lake. All are so many friends here. I'm delighted to share. And the title today I'm going to share on Professor A.K. Sharma is something like him. He's a great man, all of you know. And when I went through his citation, he's from a poor farmer agriculture man. Like me, I'm also from farmer poor man. He went to UK for FRC study, higher education, but had to go to Malaysia for want of living and help as a daily wage laborer to earn money to my family. That way. But he also liked India to Nepal to come settle down in your own place, want to do something. Similarly, I also want to do for India something, so I returned back to Malaysia. But of course, I came after that, I studied and make it up myself. And truly, it's a great, such a great man where I'm asked to do oration. It is really looking at so nice. And way back in 61 itself, he established a Department of Surgery in Nepal. Subsequently, with his own friends, started 4 medical institutions, something. But he established surgery at that time. Surgery was not much. I established minimal surgery. It was not much at that time when I started. He started 4 institutions. I also have few institutions and for minimal access surgery for training purposes. So looks both of us so going same. But he is a great man in the way. He is a chartered president and considered father of Lionism, and also considered father of oncology in Nepal. And he is also philanthropist, charity running, helping the poor. That way, I think this gives me wholehearted and happiness that to give oration in his name. Thanks, Sunil, for inviting me to this oration and chosen this oration title given me and for this honor. And here, I'm going to talk on just like a cow. As a farmer, both of us, cow is like, wherever greenery is there, it will go. Finally, you will not be happy. Today, I'm also going to be like this. I don't think I'm going to be happy at the end. And this is where it is. So, I wanted to do something to convey the youngsters sitting behind. Most of surgeons sitting in the first rows are achievers. They have achieved something. They are known. They had their own way life. But youngsters, something has to look at. What life has to go. I want every surgeon to be an innovator. How innovation? Is it go to animal lab, work on making something new, or something research making it everyone award winning globally? Not necessary. For me, and if you want to do any surgery and make it low morbid, make it safe. That itself you want to make it how. That's something you have to do with make innovation. Again, you have to make it simple, reproducible by every surgeon. So that means it was not that we have to make it reproducible by all surgeons. And I take eye cost. That was the laparoscopic surgery when Americans introduced first time. But it is also affordable cost. Europe and America, you cannot look at that. Even Chinese said in our stage in 2003, looking at Japan, America, we thought too costly not to China. But my visit to Coimbatore, India, outlook changed. And Indian wants to to China. That's what he said in 2003, after almost 14, 15 years down. So we have to make it cost effective, and the common people should be accessible. Then we can consider that science is successful, that we need innovation, something to do with more. And minimal invasive surgery, those days, by some people goes to the hospital, stay there with the cooking room or side room also will be there, 2 weeks, 3 weeks, 1 month. That was a kind of, I remember Northeast India, Nepal, and all people comes to Vellore, those days, stay there months together, take treatment. Now, everybody hurry, they coming, want to do within hours, want to start, because life will be mechanical, everybody's. But I was interested in fast recovery, not for affluent people, the farmers, the laborers who can go to get back to routine work faster. That was my intention. I took interest in laparoscopic surgery. And I want to make it in rural India and everywhere. That was mine. So all these were my intention. And why? Because you look at my own background like this. When I was doing a MS, then I realized that importance of this. So that time no MCH in gastro or no MCH in AMCO in India. And then I have to make it that way. I want to become GA AMCO surgeon. And later MCH came, I could do MCH gastroenterology. But my interest continued oncology, whatever I am going to talk more on this way. And so let me develop small way. And for youngsters, how to innovation we can. And see, a laparoscopic gallbladder when came, simple gallbladder was the indication. Next acute, next difficult, like step went in. And those days, and if any gallbladder clips endoloop maximum, that was the trend was there. In 92, a patient came to me referred by physician, cirrhotic liver, difficult gallbladder, and was working on up to infundibulum goal beyond portal cavern operate. So as a GA surgeon, in open surgery I do subtotal, dividing infundibulum, suturing and take it out. Similarly, I want to do it, I divide infundibulum, everything. Then I have to control stem. No suturing has been described at that day. And then what I did, okay, I took a little wider, put to the trocar and suture it. I never considered this innovation at that age. And subsequently, and see, this is simple technique. Mind, if you desire something, you can make it more simpler. So the only thing, how to go to the trocar, that was the only reason, nothing else. Then look at, I'm putting the trocar. Then you can suture like this, tap, everything, When once you learn suturing, wherever possible, you can suturing using conventional needles. And see, this is a ski needle. Later, Western people brought for suturing advanced laparoscope. I don't know how many of you use, very difficult to use. Unfortunately, it was not available in India, so I could not use, I could see those surgeons how difficult they were using it. Then, once I started doing conventional needle, every surgery, GJ, stem closure, hernia tap, peritoneal closure, mesh fixation, everything for me looking like a simple, I was doing it. When I presented this video in Luxembourg in 95 during World International Congress, whole surgeons were surprised looking at me, hey, something is suturing like open surgery, simple, faster, and like, that way every whole delegate started talking the way, and that was. And then, that is the stage everybody used to call, Palanival for them difficult to use, they will call, he is a master surgeon. Then that day it slowly came, it is named as a Palanival suturing method. That company made a ski needle and a ski needle shape, C-type can go to trocar after this presentation only, that make it. See, look at this difficult acute gallbladder empyema. After removal, I cannot put a loop, I cannot put a clip, but I could suture it. So the same patient after suturing goes home within a second day. If at all you want to keep for antibiotic, you have to keep a little more. Otherwise, no need for it now. See, suturing can be done. So if you do suturing like this, any type of difficult gallbladder, you can manage it, no? So that's why you look at cirrhosis liver or this, the modified gallbladder system, cirrhosis liver. When I presented this Philadelphia, and this paper was the whole conference best paper, I was so happy. And they asked me to give a write-up immediately for special article. I am fond of operating it. 6 to 9, 10, 10:30 was my free time. I did not find time to give at that age. After 10 years, I gave it, came in Journal of American College, Jack. It is Jack's president, in fact, Sajid's president, in his origin 2008, quoted mine as the best technique, safer technique in that age. And again, I did not keep quiet. I improve all how to do subtotal cholesterol modified different way, and that won the World Congress Best Paper Award in 98. And these are the ISSNCON Society's president, all of them, they were to photograph with me that time. So these were this. But same conference, I showed some of the new videos also. Then all videos carrying something which is suturing only were possible. For example, diaphragmatic hernia, choledochal hernia, achalasia, everything. And I am going to narrate simple. One lady came in 96 to me, pregnancy 6 months, and she came with a problem, came breathlessness, oliguria, dehydration. Then I could do laparoscopic bowel-like hernia repair, taking down the spleen, colon, everything into the abdomen, put a mesh. I did not have composite mesh, I would put a prolate mesh. The lady left the third day, went home, and regular delivery, female baby. That baby grown. See, she got married. Now she has got a 4 years boy. No? This is the lady I operated. So that type of things, that was the world first adult diaphragm hernia repair. But Japanese surgeon has done already for, no, that is called, this is the first only, pediatric also mine. Second, and one patient, a boy came and asked me, sir, I have a hernia, sir, something you are doing new, can you do it? He asked me. I said, 92, I only one technique I know, plug technique, no? Mesh, putting in a mesh into the canal, then suturing the internal ring. That is only technique published article 92 before. So I did it. The patient after 1 week came, sir, I have 3 testes, sir. He was no complaining, with happiness coming tell, no? Before surgery was not there, after surgery 3 testes. Anybody Western country would have sued me. Then I would tell the boy, this is a mesh which I put in the canal has come down, nothing harm. I took it to the small etc. They pricked me, something I have to learn proper way doing it before, no? Then I went to America, and 92 there was advanced laparoscopic training course at Cincinnati. That Johnson guy told me, if you buy this hernia stapler, you can do proper hernia repair like what you would tap or tap, no? 3,000, that amount I did not have. I borrowed money, went from India, bought this. Americans told me this guy must be cranky guy, no? They told me. No? And I said, I will prove you are all cranky. That's what I told them. After coming here, I did 50 cases. 4 got recurrent, all the 4 recurrent at the Cooper's Lake, where I used a stapler. I know suturing how to do, no? That time small mesh only used, 10 by 7. And not like nowadays 15 by 12 or something. So abdominal wall I sutured with the anterowall suturing. No recurrence there. Where I put so much money, only recurrence there. I throw that stapler. My sister has got a monument like in a theatre still now lying there. So then what they said, cranky proved, no? I am cranky guy. So always sensible must be before spending money. My wife also used to say the same thing. You are just spending so much. And again, I present this pediatric hernia because I know how to internal suture and repair. This was this. And I published pediatric hernia first time in pediatric that time. See, this is a hernia journal. You all know, many of your friends today mentioning that I am using a hernia book all. And I did the ICS first hernia repair. Subsequently, I did all the innovation more. So Korean Society took my book as the textbook for them published in Korean language, similarly in Chinese and Spanish as well. So this is a 4th edition now come. It comes each chapter with the videos. First time in India I made it. Any chapter will finish, kindly you can scan that for last chapter. We will have a video of that particular thing, and it is worth and then you can go through. So initially I was doing a tap because I am convinced. McCartney taught me in Cincinnati how to do tap. Mine did not accept it. So I started a tap approach because gallbladder appendix I am doing so easy for me to do it. So 95 I could see, 90 to 95 I moved. At that time, McCartney taught me subumbilical trocar one side port. I wanted triangulation and didn't do. 95 when I moved, I made a triangulation making a port on either side, and you can see lateral port, 2-hand technique. I could do dissect either side any level. I can go wider dissection. And because subumbilical trocar is difficult to operate, irreducible hernia, large hernias, recurrent hernias, and this one. And John Dees, my friend from Colombia, he described a technique, E-tape. It is very popular, world over, everybody quoting it, E-tape. Reason, no? That McCartney technique difficult to operate. With this technique, you can do both bilateral hernia, this. But port placement initially has to put one side only has to struggle. And in fact, this technique which I described 95, George Dees does in 2010. But I did not know name it is a E-tape, no? I should have named it E-tape that time, and because it's wider expansion can do it, I could not do. And this is a lateral port triangulation, 2-hand technique, any size hernia you can operate. No conversion to me other than strangled hernia. Seroma, you can ligate the sac or a case exercise sac, seroma also less. Wider dissection, both sides. So I once seen my video 98 at Rome. They invited me Argentina to live. So when I was invited to Dhaka also, I showed a live in 98. That time, my first time workshop held Dhaka. Similarly, went to Sri Lanka, 98. That year, everybody looking at something live. I was going all around, wherever. So that was done. See, small video clipping I show how it is subumbilical and end rectus sheath is split. Put a trocar between the rectus muscle and the post rectus sheath. So my camera is at the level of the umbilicus. See now one trocar right side, another trocar left hand, so two hand. By this you work like you can work any difficult hernias. Even though my mistake putting a trachus finished. That day I want to stop. I never touched trachus or Johnson and this. See nicely you can suture more effective. One suture enough. Now the mesh size is 15 by horizontally, 12 vertically. No need for large size mesh. So, and this was the inguinal hernia. Again, ventral hernia, Western people described iPod, LeBlanc. I did few cases in our Indian ladies, Nepal also, where Asian ladies, general abdomen is flabby. And after delivery, still more hanging down. There, if a repair, still the hanging down abdomen will be there, no hernia. But ladies not ready to work immediately after my repair. That made me how to do that. My intention is to work them faster, no? So what I did, like open surgery, I closed the primary hernial defect, I closed. Laparoscopic, I know how to suture easily, no? And mesh fixation also, suturing, no tackers. When I presented these 720 cases in America, and everybody surprised. Oh, this only lacking, you made it. So this was accommodated herniaplasty. And so this is an I-named accommodatoplasty. Any child born, you should give a name. If you don't give a name, somebody will give a name, no? So I will tell you why it is later. So here you can look at, I am taking this is a regular open suture loop ethylene. So I am using suturing. If those days I am sure Western people really look at like this, see, taking suturing, very simple way learning. My residents first year they learn this only suturing and they become more confident. After that place a mesh fine. And after this, the advantage is seroma less, recurrence almost 0.6%, and contour regain, and cosmetically is better. And I published this article in a hernia journal in 72 cases. Kukleta, my friend, Switzerland surgeon, after my article read it, very happy, and in Harvard herniaplasty, he put a name IPON plus. When he put a name, everybody say IPON plus as though he is innovated, but it is our innovation. He has in this article nicely quoted, but sometimes, then I wanted to become a little more smarter later. So diverification, like take care. Indian people, diverification is very wide. You have to prepare as a recurrence more common, and so function also will not improve. When I published this hernia first time world, I did a show. What I did, I made a Venetian blind folding technique. Venetian name, not like Indian ladies, and money person there. You pulled it, it folded nicely in a simple way. So that we named it now. Today, anywhere in the hernia, if you do robotic, laparoscopic, IPON plus or robotic repair, plication is what we described. Defect closure also what we described. That carries the highest success rate today. I am showing, those days I have used those suture, no? It is very loophole, very difficult. Now you can see, now all companies have got a barbed suture, very nice rolling. This lady came here and asked, sir, everybody calls me, are you pregnant, are you pregnant? Sir, my abdomen, so do something. So I was demonstrating 15 centimeters width, diverification recti. I could placate multiple sutures, one right to left to right, then finally pull it and comes closer. So abdomen grip increases. Then over it you put a mesh. I did a CT at the time of before surgery, immediately after 1 week, after 3 months, 6 months, very good technique, and that way it is more important. Then subsequently, not development came. And what we did, PTEP and George is ETEP, all evolved ETEP TAR procedure will become very important for abdominal wall closures. And here the most important is large hernias. Our people don't come to doctors immediately. So abdomen size reduced you can't put it contents inside. We have to increase abdominal capacity before putting it. For this, there external component separation and posterior component separation can be done. So that component separation by dividing one or two muscles without nerve injury can be done. So we published first largest series 250 cases, and we did a YPOM plus and the ETEP comparison, which is better. Both are standard, but ETEP scores over this, but difficult doing it. See just Excel trocar, I'm using it, go to the rectus sheath and the post rectus muscle, and you look at very easily. Now create a space, then putting a 3 triangulation trocar, and shown to you in Televersity. I don't know how many you've seen. If not seen, Televersity of German Hospital, you click the videos live stage which shown globally, and 2 months back it is there. Every step we discussed. And this is one case, large hernias like this. So you can appreciate, and see, very large. I cannot put immediately mesh. See now, same way, it is external component separation, my own technique, using external. I am going between the scarpa fascia and external oblique aponeurosis. See, it is like a board. Then introducing this instrument, now you can see, very simple way, no subcutaneous fat you so don't see. Anteriorly scarpa fascia, posterior anterrectus, in between I am going. I can go up to inguinal ligament. After that you can see I will be dividing it, and you will get more than 10 to 15 centimeters width, you will get it now. No neurovascular injury will be there, we will be seeing it and take it out. Now see, I am marking it, external oblique aponeurosis. See, now, very easily it will separate. Then look at, Western people describe going between the internal oblique, external oblique, a cut in the roof. I go between outside and make it up. See, very nicely you can see, no bleeding and no seroma drainage tube not needed for this, one can do. Now the capacity increase, I can do like a intraperitoneal IPOM plus, I can do it. See, such a wide one you can. And so these are the things, something we going. So sometimes, cholecystectomy is one of the things initially, and Japanese surgeon did in pediatric first case, I did adult first case. So look at this video on Sages Award, and also in 2008, Blumcut carried, my article is the first change in minimal access, they quoted in that book. This article is published. So, one is gone now. I think that video, I will come later, I think it's shift. Now I go to fundoplication here. This is giant hernias, a regular fundoplication. I think you listened to the lecture by our friend Yashod. Now see, let's be dissected but sutured. But this case likely to recur, so I have to place a mesh. If you don't want to place a mesh, I described a technique called double breasting cruroplasty. And that video is slipping, I don't know what is that. Today copying it is misplaced. And this is polygraph which I mentioned, and I will show video. Some rearrangement not done. So here you see, achalasia cardia hellas is the best technique. Now poem is coming up. This patient multiple dilatation done, muscle so much hypertrophy, but everybody medical people raised when I showed first time 94 mucosal injury. When they said mucosal injury, I described the scissor. Without injury, you can do this scissor is I described with a boot. I can use cautery without any injuries. If you do another problem is recurrence. If you use a tooth posterior, recurrence also you can prevent it. So that way it is safe technique. And suppose a patient comes to you grossly dilated esophagus, sigmoid esophagus, or hellas done failed. That case, you can see here I am showing a technique I used to do before transcital. Now thoracoscopic mobilization, you can see the sigmoid esophagus. How much grossly? More than 10 centimeters, no? Actually, barium it was 15 centimeter diameter. I did a resection with thoracoscopic, took a gastric tube, Ivor Lewis, the site to anastomosis, and put a stay, then across a stapler, completely stapler suturing technique. I will show when cancer. Even proximal, I can sleeve resection done, make it narrow. So that way, this is one of the, this is a current trend for sigmoid esophagus. Another interesting Acacia lady, and she was pregnant at the month, third month she came to me, and I told her third month if general anesthesia maybe is problem, why not go dilatation, come on after fourth. And twice dilated, no response. She came fifth month, her husband told, sir, you do operation, even the baby, anything happens, no problem, sir. This lady is not eating. Without undernourished baby, I don't want. Let the, operate. And the fifth month safer, no? So I did a Hellas laparoscopy. Then this lady delivered a baby, very happy. The article also published first time in the world, pregnancy Acacia. But unfortunately, her husband, who so much affection, he died in an electrical shock after a year. She came and asked me the photograph which took first year birthday celebration. And so each short ASA she can lengthen, and sigma ASA I already told. I used to transital. Later what I did, change 42 cases, then sigma ASA is now. See, even a transital wanted to mobilize, we can go up to the neck. So you can see now, this type of dissection can be done well. And this is a baby I told, no, polylocal cyst video displays. Now you can look at, and I want of time, I will show you. See, dissected, and mobilizing decompressed and taking down. See, now, see, very, very narrow. As it goes down, you can put a clip and dividing it. Then finally make an anesmosis, epiduralostomy. Even epiduralostomy want to do it, also can be done because magnification is so good, very nicely done. The recovery time is 2 to 3 days, and they have no ileus, they can go back. So, and also one case, adenocarcinoma came, you could do it through transaxle approach. This is a repeated changing, I will go. So again, transaxle approach we described, published article in the beginning. See, this one, diverticulum, under endoscopic guidance and put a stapler at the neck, then excised it. Followed which we have to do myotomy. And another rare intestinal sometimes comes. See, a fellow while sleeping and swallowed the denture, but he did not know. After 3 months he comes. After endoscopy attempted, here, midwife she came to me. See, you can took a denture and through thoracoscopy remove. When I showed in America the video, everybody was not removal. Everybody thinking how I'm going to take it. No, whole arm was mesmerizing. Then I had to make it a bend inside. See now, so between the rib I took it out. So this also be published now. We had done 2 cases similar way. But then new surgery started coming that time. New surgery in the sense we were undergraduate. We did not know bariatric surgery much. We know about metabolic surgeries. Even MS I did not know. Even during MCH I was not taught. So when leprosy came, that is a time that slowly came. One ENT surgeon came to me asking, sir, I am overweight, kindly do a bariatric surgery. I told him, no, I have not done before. If you want to do it, I will do, but it will be the first case. He said, I know, sir, you have not done. See, he knew that I have not done, but still asking me. Then he told, my brother is surgeon, sir, he has attended every time I come to your regular workshop. D2 gastrectomy and control live. This simple sir for you. That's why someone, the young brother told, you do it. I did it. So happiness he came after some time. So every time, everything falling down, I have to ask, and at home, my wife and children, in hospital, I have to depend on the sisters, boys. So now I'm able to bend down, I can do shoelacing. I'm happy about it. No, so happy. But still I'm afraid. Subsequently, still I'm waiting. I did not want to attempt it because that was the first bypass in India. Then subsequently this boy came to 10 kg, then operated him, now 2 surgeries done. Huh? Now I'm looking fatter than the guy. That boy got married, after marriage he delivered a baby, that baby was named Praveen, my son's name, because he wanted to remember our family. He's health minister of Tamil Nadu government, inaugurated a department long time back, and Rose governor gave me certificate of Center of Excellence. The another interesting is, they came and asked me, sir, so much you are doing laparoscopy, why not do donor? The wife gave a liver to her husband. It was done the previous day. The surgery was at 10 o'clock in the night. And next day morning, she was fighting with the staff nurse in the ICU, the staff doctors. I want to go to my husband's room. They were in the ICU only. Then went to the room talking there. Then she told, we are lovers before marriage. So today is Valentine's Day, I have to greet my partner. So what gift one can give more than liver, no? The best gift can give that my wife gave to her husband, no? Very nice, happy, that's why this photograph I will show you. So these are the benign way life journey to going through. Same time, I became a GI surgeon for oncology purpose only. When I was doing MS, cancer esophagus, general surgeon, rarely, no? Cardiologist rarely doing it. General surgeon never, not single case solved during my MS. That made me, why not become a GI surgeon, no? That's way. So after laparoscopic surgery, most of the cancers today standard of care and higher cure rate and morbidity recovery. See, I went to Spain. There was a live workshop asked me to do gastrectomy, and the patient was admitted at 1 o'clock. Why not at 12? I want to see the patient. No, we at 12 o'clock, one day room rent. No? One day room rent in Japan, Spain was 700 euros. Oh, India, that is a cost, total cost also will come. So after 2, I saw the patient after the evening. By the time we reached Coimbatore, 40 days the patient got discharged, went home, sending me a mail. Thank you, doctor, operating me. I'm very happy doing well. So how fast the recovery due to gastrectomy? No drainage tube, no rails tube. She able to overtake oral fluid. They say even gastric bypass, whatever you do, no rails tube. Same day we give oral fluid. They discharge next day now. Same way it is all changing faster. More than that, unaffected immune system is the most important, and long-term survival is better, recurrence also less. And quality life, very important, particularly thoracotomy, laparotomy, neck. So imagine how the patient is going to recover. Now, I will show you later how it is being done later. No? So this is the first, I will do colon 93 I started. Colon, distal pancreas, gastric colon, everything I was doing. But one procedure I was not I was about to do, but Michel Gagne showed a video in Philadelphia, said, no use, I did 9 cases, leak rate, more complication, I stopped doing it. I saw he is an excellent surgeon I knew, but that procedure he didn't do well, he not done well. So I decided to do it, Coimbatore I came, then I did, one Sunday I chosen a patient, I did it. That patient married 3rd month, jaundice, C. pancreas. I did a Sunday, of course 11 hours I took it, and that was the world first Whipple operation for laparoscopy at Coimbatore. And this is a patient, and I first baby, second baby, and they were regularly every year used to come. When Olympic medal competition was held in America, and I was chosen for Whipple and breast gay for liver, and Varisa Zalki for rectum, like a different surgeons, stomach for Japan. Finally, that Whipple and breast gay came equal. In order to avoid tie, breast, senior, he gave gold to him and silver to me. And now this man lived for 22 years, the first Whipple operation, and died during bypass for cardiac. Disease totally gone. Huh? That way, cancer also can show it. And this video sages 2000 award winning, and live surgery demonstrate more than 40 countries. But the problem is convincing. Our friends also telling locally some opposition always will come when you introduce something new. No? Not only that, people when introduced, 1 year I was stopped for running a course, postgraduate course. My own friends only in the committee. Why introduce that people? No, it is not standardized. Standard booming. Somebody has to make it standard. No. As long as I can, sure, like that's why I did the 2007 live operation. British surgeon, one screen open, I was in lab people. Everybody thrilled, more than 800 surgeons. Buchler again, these people not see laparoscope, talking games. So Buchler is Heidelberg, very great surgeon pancreas. He was doing open Whipple, I was doing a lab Whipple, same time, same screen. Then he agreed it is the best way to do technology. And additional 2 millimeter duct, I could do end-to-end anastomosis. Then he saw that's not possible in open, I agreed. And again, everybody said robo laparoscope. That CM Tang is a Hong Kong surgeon, is a great surgeon in robotic surgery. And his training center is Asia Pacific Training Center, I'm also regular faculty. He told, I will do robotic on screen, you do laparoscopy on screen. We did have come together. I finished faster than him. Then he said, I thought Palni will come on bicycle. I was going a Benz, but finally cycle went before me. This is where he commented on the stage. So you can see all the great people. Giuliano Di Vitti, the robotic people was there. Leroy and everybody there that day and to address it. But still, I myself also felt technology will help. I'm doing more robotic now, both people is I guess. But I have to do chess now. But we need a prospective study. This prospective was the world first and RCT, published and won the best paper award at the World Congress. My colleague Sandil Nayan got it, the best paper award, published in BGS. Then they asked me to do guidelines in a Korean meeting, and they said we should have guidelines to promote because it's too complex. Then all of them came to Coimbatore, my old center. We did the first international summit. That guidelines got published in the name of Coimbatore. I'm so happy that usually Tokyo, London, Boston, Coimbatore, not Coimbatore, and came in a way. I was so happy. So this is robotic ports. This is a laparoscopic ports. And camera I always keep to the right of the applicator so that unseen accession can be easier. See, just a small video clipping and show. I think my editor little faster. It is not that speed I operate. My colleague sent the video now, copied it. See, I'm mobilizing the cooling down. Second, third part I'm working it. And focus maneuver, we do extended focus maneuver. This IBC, now we are going towards IOTA. And we take IOTA cable nodes for sampling. And now you can see survey here. And this left gastric vein you can appreciate, then come back. And you want to tunnel making it. This is a gastrocolic trunk, we clip and dividing it. Then go making a tunnel and controlling this. Depending on the pylorus preserving or classical, you can divide duodenum or stomach. Then we go for the mobilizing it up upper border. We divide the duodenum. This is pylorus preserving. Then lesser omentum we divide. We want to control the GDA first. The artery first approach I follow in all cases. So look at GDA, you put hemolar clip. Hemolar clip prevents pseudoaneurysm. And titanium or suture, pseudoaneurysm bleeding is more. Now we are working out controlling cystic artery, cystic duct. This is actually shown a live operation that I did keeping it here. Now you can see tunnel, portal vein and going down. This is undilated duct, what I used to do, my own technique, tying with a cotton tape. By 10 to 15 minutes the ducts get distended, so you can identify it well. That is hemostatic suture. So I go DJ flexion mobilization, coming down. By the time the duct gets distended, I can go for a pancreatic fusion. See, now you can see the jejunum DJ flexion comes to the right side. Now I want to divide it. Energy you can use everywhere, not at the duct. That's why I changed to scissor and without any able to doing it. This is also my own instrument traction is on. This is a dynamic traction using rubber band, both the uncinate divided pancreas and the GGC. Now, under these uncinate over, under both way you can see, without anything can go. And the SMA is pulled to the right side. So I can clear the SMA artery so well. Now you can see SMA here. SMA, see, normally it is supposed to left, but it is on the right side. So now you can see the clear done. Pulled out clamp for the CBD. And now finally we divide the CBD and putting it. Now we'll take a look. This because a lot of people ask me, sir, people you have done first time want to see how it has been done. That's why this video I'm showing. The rest of the thing I may jump. Pancreatic duct. This is again I modified my own suturing is. First and last suture is plumb cut modified suture. In between I show a continuous suturing dunking. So you can look at 40 PDS continuously coming down. Then oh, sorry. See, after this, and you can see continuous suture, then I will go. And you can see, again, I learned from my friend, the Chinese guy, Shendu. Big Bang, he shown continuous duct anastomosis is a reduces leak. I also did almost 250 cases I've done this technique. And no leak in my last 250 cases. I had a few leaks in the beginning. Now this is a very good technique. And finally continuing the 4-0, then finally the fourth one I'm making it up. So this is gives a perfect anastomosis and again tension free, making it a mesocolon to the side to keep it more. So then that anastomosis you can do it more. So robo, same technique where in a prospective study you look at and DJ second, third part. It is 92 harmonic, you can see. I will see. Left hand I am using a fenestrated bipolar instrument. I retract the gallbladder by traction, a different one. No instrument will be there on the liver, everything. So I left renal vein and I have to carry notes, taken biopsy, same way. And anastomosis you can see, same technique I do. I did a open laparoscopic robotic comparison, and this is a standard technique. Now we make it up. I will go to that one. So now this another esophagus, my own technique which I promote across the globe, prone esophageectomy. All types of transhiatal, 3-stage, McEwan, 2-stage, I will use all we did. This is McEwan I am going to show videos. And do look, French surgeon used to come to Coimbatore, so he has seen me operating it. I have not published that time. He invited to Bordeaux to show a line. There seeing it, I was invited to Manchester to show live during that association conference at Manchester. I have not been UK before, no FRCS, no training, but an Indian given a first time privilege to operate in UK. Subsequently, every year I am going there. But the most important, these two surgeries, India 2 places, one Cochin, another Ahmedabad, Japanese surgeon were there to see prone esophageectomy that they have not seen before. And lymphadenectomy, they said it can't be done like open. That's why they didn't do. Till that time they were not keen. After seeing 2, they were told Japan, this is what Indians showed. Then I was invited to Hong Kong to perform live during ELSA Congress. When I showing that Chinese, Japanese, Koreans all saw, and they, till then I were not published. Now I always found this is where Indians were lacking. Then they compelled me, unless until you publish, Japanese cannot do it in Japan, they will, anesthetists will not accept. Then I published my write-up. Once this article published, I got an invitation to go to Kyoto by Japanese Society, run a course both on esophagus, prone esophageectomy and nipple operation. Normally Japanese used to come teach us. This is 2 places we were taken to go there. No? And this video won this American College Award, European Society, World Congress, all the places won. My robotic esophageectomy twice been PhD award at Taipei and Seoul, Korea 2020. And here the advantage is excellent exposure, no lung retraction due to gravity and partial ventilation, lung collapses well down. And anesthesia point of view, double lung ventilation, single ventricular tube. This is it is our own way to project. My anesthetist felt it. It is way it is. Post-op, during surgery, even take 1 hour extra, no saturation fall, nothing. That was the outcome they saw. And that way, post-operatively also patient recovers like any other surgery. If I say, see again, surgeons ergonomically more comfort. No fluid stays there while operating site because gravity. So you can clear nodal dissection and even bleeds you can suture or put a clip. Learning comes shorter. That's why it is very important. See, small video clipping here. See, once partial pneumothorax, lung collapse into anterior compartment. No retraction of lung. Entire mediastinum is exposed. Now I am taking the left inferior pulmonary ligament. Now is the esophagus arch. Put a hemolar clip. Initially I used to ligate suture. Now my friends have seen a simple way. One bronchial artery we control and take it up. And then see, tacking after anterior dissection what we do, tacking the esophagus to the periosteum. And I want exposure to the left side of the paratracheal fascia and vertebra so that I can clear the nodes. Look at very simple. If it growth in there, in the middle esophagus, then I can put a cotton tape rubber, then that can bring out to the anti-posterior chest wall. Now you can see there that lacrimal now, pulmonary artery, you can see here, taking all the nodes. Oh, my sensitive, my finger. See, and then some posterior dissection now. I don't do posterior because blood trickling away from down, no? That's why. Now you can see aorta completely as a thoracic duct here, it is preserved. Medius pleura. If a medius pleura involved, we can take it out. No problem. And double lung ventilation will maintain. Now you can see the left lacrimal and dissection. Now here, abdominal phase, what I do, I'm making the stomach mobilization. And after greater curvature, mobilizing it, we'll go for lymphadenectomy. You can appreciate the left gastric pedicle. And after this, we put a clip, taking node, then we're dividing it. Then after this, prepare the lesser curvature, and first cartridge always use the blue, golden or green. Subsequently blue. 5 to 6 centimeter width is very essential, and finally you can dividing it. And so now final dissection at the hiatus, and after mobilizing, then we go to the neck. We stitch this to the specimen side. No? See, now we divide the esophagus. First, right tubes attached, over which a plastic over tube, and that over tube will come to the abdomen, and through the over plastic tube, a specimen can be taken to the neck, and the gastric conduit also will be pulled up. Carefully, you can look at nicely. It will go to the neck. Then the neck, we do always triangular staple anastomosis, and leak and stricture is a problem. Now we don't have a leak, a stricture any of my cases because of triple staple anastomosis. Same thing I showed in the chest also. Inside you can do it. Now stapler is like a vertically mounted, one across, then subsequently. Immediately you can look inside, wide stoma, tension free. And a hiatus repair has to be done, otherwise the herniation can happen. 2 of cases had herniation going through. So suppose in case do a gastrectomy combined. This is also being described first time, substernal placement of conduit. And I use the right colon and ileum, distal ileum. And see from the neck, my finger is coming in here. And same plastic tube and the right tube is coming. We attach the ileum to the plastic tube and take to the neck. Anastomosis in the neck the same way. It can be hand-sewn or stapler. Either can be done. Okay. Gastric cancer is a very common problem in India. Any type of cancer, distal, total or proximal gastrectomy can be done. Our video 2004 won the Sages Award, and Japanese invited me to give keynote address because of the reason, and I already told. So you can see how clearly one can do this portal vein, common hepatic artery, splenic artery, and pedicle control clearance, all can be done well. And anastomosis also can do laparoscopic, no ileus, no need to put rails tube. Right? The colon cancer is very common problem everywhere, Asian countries, initially Western countries, and here they described CME, complete mesothelial excision, with a deep lymphadenectomy. And here we modified the medial lateral approach. Medial lateral is Western. I modified it to IRITA, that is irretroperitoneal tunnel dissection, then proceed. It gives enhanced view. And now you look at here, and the port placement I am making it. See, this is where root of the mesentery, I incise up to duodenal flexure. Goes between the gyrotous fascia and the Tal's fascia up to the second, third part of duodenum and the duodenum. Now you can appreciate here. See, now I duodenum, head of pancreas, and dissect. This medial up to IVC and this I done. So lymph node clearance maximum here achieving it. So laterally here. Then after this, place down colon, all everything the normal position. Then we work on here. We preparing the mesentery of the jejunum, and you can appreciate taking it up to the DJ flexion, make incision, and ileocolic, middle colic, and all can be here well dissected. See, now appreciate here. So you can appreciate all colic vessels individually, and you can appreciate. And this technique, when shown live, Korean friends who came there, they saw it, appreciated, and even now the robotic also chose most of the colon correct surgery, they do same way interperoneal tunnel and laparoscopic robotic. Now we are preparing the mesocolon, and then we prepare the great omentum, and see now ileum we prepare and we dividing it, and this is transverse colon piece of blue, and ileum. And after this, intracarpal anastomosis is a current trend. And stapler, side to side. And after this entry, we close it. So every surgeon, the suturing, if he knows well, and no difference between an open or this surgery, you can make it up well. And this type of no drainage tube, and orally start within few hours. Once recovery over, it will discharge the patient in 48 hours. So liver also, I think they all you have been seeing, and this is a nose. I don't know many of you remember that nose. Word coined by me, and first article published. See, this is taking the specimen through natural, anus, vagina, or oral. That's been named. This lady delivered already 2, hysterectomy done. So colpotomy doing it. We have a cone, place it, taking a plastic tube inside. You can look at, and the specimen goes through the plastic tube outside. Vagina is the most resistant for cancer, no problem. And this is protocolectomy. Then I am taking a specimen outside. Any anti-resection, if a lady accepts, I will go through this way. Otherwise, anal I will take it up in male. So look at this. Such a specimen can. So this is nose procedure, natural orifice specimen extraction, nothing else. Last video, and here, this is gynecology, retroperitoneal dissection. I use a rubber band for here. See, 4 or 5 rubber bands I'll take it anteriorly, like this, either side, no instrument. Now you can see the ureter, this side you can see, this is a common iliac, and we incise, as we incise, rubber band pulls laterally, it exposing it. Now you can see, so iliopsoas will go down. Sorry. See, now you can see IVC, and aorta, over the aorta we incise the tissues up to left renal vein. In gynecology they say left renal, okay. In case of otherwise, if you want to do a rectal cancer, up to aorta, esophageal hiatus, you can do pyroaortic lymphadenectomy. Now you can see aorta, and go between the aorta and this also we can take the tissues. See, we can take complete tissues because exposure is so good, one can do it. Energy sources like ligashule or harmonic, so nice, one can work well. Now the left side, we can, taking the notes, you can see iliopsoas muscle, left ureter, gonadal artery, this IMA, and like this. See, now look at anatomy posterior. No instrument retracting, but we have such a wider exposure, we can do this way. Okay, I want to finish up. So single incision, very good procedure. I don't know why it was not popular. We did the world first distal pancreas, total protocolectomy and resection. We presented in these ages. Every year when we presented, we gave the best video. Basic procedures, routinely do. And of course, now people are not preferring it. Notes also, we published first umbilical polycystectomy and this. Finally, I think we are all putting all our experience and textbook form. This is the 2002 came and 2005. Now we have 4 volumes in this, and these are the 4 volumes. JP is publishing it, and when they celebrate Silver Jubilee at Paris, the World Congress time, European Society wanted 102 surgeons, the maximum contributors. They sent opinion input across Europe. I never expected that Europeans will give the John Hunter and we were nominated for the maximum contributors award. Now specialty has grown so much. Esophagus separate specialty, all these. Any of the surgeons interested in post-doctoral fellowship, most welcome to one of the course. I am very happy. We have a televersity, 4K 3D transmission. Amasi has got initiative every month, one per live surgery will be shown, and 3rd Thursday afternoon. And anyone, last month I showed a lab people, 1,500 surgeons attended from 40 countries. Now in the coming December I am going to show 21st distal pancreas. January I am going to show esophagus. We showed a hernia, E-tip also. Those videos are there in the televersity. If you link this December, you can pass videos also can see. But January they will take it and they will make it take it off. Before that there are 5 interesting videos available. And the first skill course I conducted like MRCS at Coimbatore. Now 100 course coming Coimbatore. Only 100 candidates allowed. It is something interactive. Live surgery, master video, crash course on hernia, aperture, colorectal, all is there. Bariatric, new technology including robotic. Do come, register at the earliest. It will be nice. I am happy. Apart from this, we have post-doctoral fellowship HPB affiliated to the University of Gem Hospital. And MRC has got a advanced fellowship course called MMAS, upper GI, hernia, colorectal, and HPB. These are the courses. Anyone wanted to can come. It includes live surgery of a day, 3 days. afternoon lectures, videos, and interactions, and final assessment. Anybody register, then 1 month before we take a master class, online courses you can learn from here itself. So this is college, Amasi College. We started a smart training center. Jugendra, president that time, inaugurated it. So thank you very much for this honor. Thank you.
25 years. I was an intern when he was doing his MCH in Madras, and I do know his humble backgrounds. And as he truly said, he comes from a very poor background as a farmer, and he actually went to Malaysia at the age of 20, and he struggled as a laborer, and he worked hard, and he came back to India to study. He has gifted me his book, his biography, and it's a wonderful book. I've read it, sir. Thank you so much. And he's the only surgeon in India who's received the BC Roy Award twice. So let's give him a great round of applause again, and thank you again. Thank you for coming.
Today because I could see my professors and teachers here who taught me, who groomed me up, and today I'm here hosting this session, and I'm very happy, honored, and also nervous in front of you all. So please forgive us if we do any mistake during the program. Now,
Beautiful performance. What do you say?
and beautiful food as well at the end.
Yes. So we are waiting for our executive committee. That is why the program is on a halt for a couple of minutes. So please bear with us.
Now, without further ado, we'd like to invite the executive committee of 15th International Conference of Surgical Society of Nepal. We're at the beginning of inaugural session of 2023. We'd like to request the executive committee to come in the front two rows. We'd like to request our band to perform their music.
Medical profession and culture and tradition together. Thank you to our army band. And along with the entrance of our executive committee to the hall, we had a scepter that followed, and the scepter is the representation of the society, and it marks the start of the official.
What is going to happen today next? Without further ado, I'd like to introduce myself. I'm Dr. Santosh Upadhyay, your host for today.
And I am Dr. Yunisha Luitel.
To start the program, I'd like to request Professor Dr. Sunil Sharma, the President of Surgical Society of Nepal, to be seated on the dais.
Let's welcome him with...
And we have two very important people. I know we all are important, everyone present here is important, but today we have two very important people today who are the guests of honor for today's program. I'd like to call upon their name in the alphabetical order. I'd like to request Professor Dr. Sudip Kumar Bhattacharya and Professor Dr. Vishwaraj Dani to come up on the stage. We have more people to come up on the dais. Please embrace yourself. Now I'd like to invite Dr. Romeo Consaka, the President-elect, to come up on the stage. Similarly, you can see the management and the whole entire team, along with the volunteers, are responsible for this beautiful inaugural session. And I would like to request the General Secretary of Surgical Society of Nepal, Dr. Bikal Ghimire, to come up on the stage. Similarly, I would like to request the Chairman of Scientific Committee, Dr. Pranil Rai, to come up on the stage.
Let's give a huge round of applause for the dignitaries in the dais. Now next, I request all of our esteemed dignitaries to please kindly rise from their seat as we are about to begin the national anthem, and that will be performed by our army band. Thank you.
Thank you so much. Wow, that was beautiful, isn't it? Now, without further ado, I would like to invite the President of Surgical Society of Nepal to deliver the welcome speech.
Let's welcome him with a huge round of applause.
As short and sweet as possible, because beyond this lies the good show of Kutumba and a dinner to follow. But this year we want a few formalities to go ahead as well. We have amongst us some very great friends who have taken the trouble of coming all the way from different parts of the world to join us and make this celebration a great success. As you heard the last two orations, this itself speaks for the standard of this conference. I would first like to welcome our foreign delegates and our orators, local and abroad, for coming all the way and sharing their experiences and their knowledge with us. I'd also like to welcome all the other foreign delegates and local delegates, especially my friends from all across Nepal who've taken the trouble to come all the way to Kathmandu, and my friends from Kathmandu who made this evening an auspicious evening by coming and gracing us. There's been a lot of soil and hard work to make this conference a success, and I'm sure you've enjoyed the pre-conference workshop yesterday, the first day of the conference today, and there's going to be a full day of academics tomorrow. So I hope that you will enjoy the rest of the conference as well. And apart from that, we've also started a few traditions in this conference. The first one is that we've started My Journey series of lectures, where we learn to appreciate our seniors who have actually toiled the soil, and they've laid down the foundation for us to go further in surgery. I think we need to really appreciate that, and that is why we've decided to call two of our senior most surgeons as our chief guests. And as it is the norm, you can't have two chief guests, we have two guests of honors. So a big round of applause to the two chief guests of the evening. Apart from that, we also have started the Fellowship of the Society, which was not going on for quite some time. It was initiated very early in when Professor Lok Begum Thapa was the president, where we've restarted that, and we're going to be giving fellowships to 5 of esteemed gentlemen who have contributed to the field of surgery from neighboring countries as well as from Australia and Japan. Apart from that, we will be celebrating the journeys of 3 Nepali surgeons who have contributed a great to the development of the surgical fraternity in Nepal. So with this, I think I don't want to bore you further. I welcome you all, and I do hope that you have a pleasant stay in Kathmandu and that you enjoy this conference. Thank you very much.
I'd like to call on stage our Associate Professor, Dr. Tonka Prasad Bohra, who is the Chief Editor of JSSN. Sir, can you please come up on stage? Thank you, sir.
Dedication, sacrifice, and dedicating the life to others. And we have two guests of honors today who have dedicated their life for the people, and who would not like to listen to them. So I'd like to request Professor Dr. Sudhir Kumar.
Sorry, I didn't have a prepared speech because I didn't know I have to speak. Anyway, the first thing I would like to thank the President and the Executive Committee of Surgical Society of Nepal to be myself and Dr. Dali to be the chief guest and guest of honor of this conference. And I wish the conference a great success. Well, to this day, I would like to start by paying my obeisance and bow my head to Professor Anjani Kumar Sharma and Dr. Dinesh Nath Bangol, who started a modern surgery in Nepal. I have the privilege of being a young surgeon, and before being a surgeon, a house officer under them worked in the old Beer hospital. And I saw the pains they had, real pain. You see, the pain of not being able to treat a patient like you would like to do, like you have been taught in the university, like you have been taught. And always said that medical profession is a noble profession. What noble profession? If you can't treat as you like. You see, when Christian Bernard came here, I talked to him. And I said, Christian Bernard, Professor, you have done a heart transplant. Does it? Somebody who lives for 6 months, you have done the surgery, and you claim that you have done a great job. What good it is? You have spent millions of dollars to treat him. And he said, this is not my job. I am a surgeon. I have to do what I have done. If the government can spend millions of rupees on rockets and aeroplanes and find everything, then they can spend certain amount to save lives. That is our profession. When I saw first I saw Professor A.K. Sharma, he was fighting with the superintendent of Beer Hospital for 2 bottles of dextrosaline to give to a patient. That was my first experience. I saw him and I knew him. And I used to call him Guruji before I went to England for my fellowship. So, and similarly Dr. Bangol, he also did a great job to see where we are today. With this Nepal, you see, the history goes back, long back. Before Dr. Sharma and Dr. Bangol, there were people, mostly from Bengal of India, who used to be doctors in Nepal. And I know history, small history. The surgery they did was just drainage of abscesses and things like that. And one Rana Prime Minister had a Whitlow, and that my uncle told me. My uncle was an employee of Rana's and he was very popular with them. He was a favorite. He told me that when the Prime Minister had a Whitlow, and he said, they were virtual rulers, the Ranas. The king was the king, but the rulers were say, Maharaja, I would like to incise. Oh, so you want to incise? God Almighty, how can you put a knife on a Maharaja? You see, they are descendants of gods, and you can't put a knife on him. So he gave him morphine, and after morphine, he was sedated properly, so he incised it without his consent. And when he woke up, he got a great relief, but he saw a bandage in his finger. And he said, who did this? He said, Falana, this doctor did it. And he said, immediately kick him out of Kathmandu. And he was kicked out, and then one of the courtiers said, Sarkar, but you have got this great relief in your finger. Oh yes, I have got great relief. Now call him back and give him a lot of money. So he became rich. That doctor became rich. Another doctor, Dr. Keshav Babu, I have heard, he operated on him. In the old Veer hospital, he tried to operate on somebody. And the patient died, obviously died on the table. and then he ran back. He straight away ran from a back door. I went to Irana Prime Minister door. He said, Sarkar, help me. I have done this. All okay. So these are the histories of, we have seen, in those days, people never wanted to come to the hospital. They said, if you want to die, go to your hospital. That's I've heard. I've heard those things, those days. People, Aspatal mein gaye morcha, that is the thing. And now you see, Nepal has developed so much. You people have done such a great job that there is a waiting list for 6 months, 1 year, something like that, for a cholecystectomy or something like that. So, those are the days. When I came back from England, I was sent to Biratnagar. You see, to say the least, surgical instruments were very few artery forceps and all that, and there was no anesthetic equipment, no anesthesia available. So how did you do a surgery there? So I had to learn surgery. I had to make my own anesthetic equipment. In those days, we used to put ethyl fluoride and open drop ether. Patient went deep and deep and deep and deep. Sometimes they stopped breathing. So those are the days. So anyway, now I see Professor A.K. Sharma. If he is there where he can look at us, you will see his son, very able-bodied president of Surgical Society of Nepal, Professor Sunil Sharma, and Professor Dr. Bongol's son is a surgeon and a vice chancellor of Patton Academy of Medical Sciences. So I am very proud of them. I have seen them in their childhood and I have seen them growing, and I am very happy that they are there. And again I thank you. At the end, I say, I must repeat something which I have been doing all throughout my life. 2 Sanskrit verses from our holy ancient books. One is, Om Sahana Bhavatu Sahano Bhunaktu Savirjam Karvavahi Tejasvi Navadhitamastu Ma Vidishavahi. Om Shanti, Shanti, Shanti means let us sit together and converse together. Let us show our valor together. Let us work for the billions and show our billions together, and let us not envy each other. Let us have no malice with each other amongst us. And, oh God, let there be peace all around. Peace, peace, peace. And another one, Om Asatoma Sadgamaya Tamasoma Jyotirgamaya Mriturma Amritam Gamaya. Om Shanti, Shanti, Shanti. Oh God, lead us from dishonesty to honesty, from darkness to illumination, from mortality to immortality. Let peace be all around. Om Shanti, Shanti, Shanti. Again, thank you very much. Thank you. It has been a great privilege to be the guest of honor of this conference. Thank you all. Thank you very much.
Bhattacharya, thank you for your witty insights, for your brave and courageous words. We could see our audiences smiling and giggling for here, and it is a gem to watch it. Now for next we have our next guest of honor, our Honorable Professor Dr. Vishwaraj Dali, and I request him to please come up to the podium for a speech. Let's welcome him with a huge round of
After listening to Pandit Sudhirkumar Bhattacharya, I don't think you would like to hear anything from me anymore. He has said so many things, not only about surgery, but also Gyan Gun. Mr. President, Professor Sunil and his experienced team of executive committee, distinguished guests, ladies and gentlemen. I'm really excited to find that the atmosphere of this meeting today is a little different from what I used to find earlier. The gowns of different colors, which is really impressive. It has added to the color of this meeting we are having. I think it is the first time this sort of celebration is being done as if it is a university education program. Anyway, this is something new is happening not only in the program, but what I find is that the absence of a chief guest. We, in our time, old times I'm talking about, we used to have a chief guest, especially politicians or VIPs, they used to call it, and we used to wait 1 hour, 2 hours, sometimes free, for them to come, and we used to wait patiently and sometimes very impatiently. That was our fate. And during those days, as doctors also, we didn't have much unity or maybe much strength in ourselves to deny that sort of privilege to the politicians. Even now, I think we are not very much different. So that's how we have come across all these years. About this surgery development in Nepal, I think Dr. Bhattacharya already talked about the pioneers in Nepali surgery, Dr. Mongal and Dr. Kumar Sharma. I was very close behind them, learning a lot of things from them all the time. But they will be all the time remembered as far as the history of surgery is concerned in Nepal. They have developed surgery right from the ground level, or maybe I will call it they have mined it out. Not ground level, but they have gone deep down at Nepal and mined it out. It's something they have produced for the posterity, for Nepal. And whatever we are seeing these days, all the credit goes to them. We have been following them, and I'm sure you also are following their footsteps. And in no time, we'll catch up with the global surgery, whatever we call it these days. We are maybe at the moment behind in the local, in the development, but in due time, I'm sure we're going to be very much catching up with the modern times. We are very hopeful of that, seeing all the participation from the. Well, people in Nepal know me as a small surgeon, small time surgeon we call it. But somehow they have never been seeing me and talking too much. My tongue is always falters before the August president like this. August college. I can't just talk long. But somehow, because you have chosen me to be a guest of honor, I have to say something wise to all of you. Though nothing wild may come out of it, I will try to do something. So, as a guest of honor, I was wondering, I don't qualify for being a guest of honor at all, because this gathering is all the Society of Southern Nepal, which I was associated right from the beginning of the inception. I'm a part of the society, so I don't qualify to become a guest at all. But over and above that, guest of honor, all the more honor. Anyway, thank you, the executive committee, for giving me such an opportunity. And as you can see, being an octogenarian, after Dr. Bhattacharya, I'm one of the senior most in the gathering. Being an octogenarian, I have been fortunate enough to see in Nepal many heroes and celebrities, especially in politics, in cinema, music, literature, sports, and so many other branches. But somehow, I always feel that in the medical field, we rarely come across national heroes. Rarely, definitely. And those who are celebrated by the general public. This unfortunate situation may be due to the modesty of our medical profession. We are very modest people. We don't want to advertise. We don't want to talk about our achievements and all that. We just keep on. Well, that's what we have been taught right from the beginning. But then times have changed. I think we should change our attitude towards this modesty. We should be more going forward and telling whatever we have done as far as surgery is concerned. Well, it might be, as I said, we started from the ground where people were always up. So we are catching up behind them. Because of that, the amount of work we have put up, amount of efforts we have put up is quite great compared to the other people. So that they don't realize it. So what I'm advising is that we must come out of that modesty and talk about our achievements in surgery, and just don't be modest. You talk about it. And once you do that, people will come to know of it. And of course, the main problem is, as I know, is about the violence against the medical fraternity, which is occurring every day, every week, or every month at least. That is the talk of the town these days. And they all blame these doctors and the community, doctors and the other specialties, for the negligence or whatever they call it. But what I've been told is that there is a definite sort of society of hooliganisms, all dons or whatever they call it. They just work behind those poor, innocent, the patients related. The patient supposedly dies, patient related. They are not bothered about asking for compensation or for pay to all that. But there is a hooliganism, there what is sort of society which they operate from outside and then cause all the disturbance in the country, in the hospitals. And now the hospital administrators are just shaking with terror whenever some serious ICU patient comes. It becomes a problem. They don't know what happens. This we have been observing not only here in Kathmandu, but also all over the country, and maybe even our neighboring countries also. Now, I think let's talk a little about the national problem, which is the brain drain. This has been a big problem for all of us, and we have been really hit hard by this. Well, in our time, for a medical education, I was all sponsored by the Polvo plan. I didn't have to pay a penny for that. I went for post-graduation in All India Institute of Medical Sciences. I didn't have to pay anything for that. So when I came back, I didn't have any debts, or not even my father had to spend any money for that. But the things have changed completely. I can imagine that people spending lakhs and lakhs, as of crores of rupees just for medical expenses. So because of that change in things, we feel we are very lucky. We didn't have to go for all that difficulties. We have been very lucky. But for doctors these days, our younger generation are really having tough time. So we as old people should do something about it. But the brain drain, of course, is not a cause of all these problems, but what I feel is that the main cause is an inferiority complex right from the school, you know. We have been taught that Nepal is a small country, is a backward country, is an underdeveloped country. That hasn't gone into our brains. We always feel that nothing can happen in Nepal. This sort of thing has gone into our things. We have learned that from our school. But I think it's high time we unlearn these sort of things. We have to have some sort of confidence in ourselves that we also can do something in the country, and that's the feeling of complex, feeling of superiority, though it's not one superiority, but at least not inferiority. The negative feeling is avoided. And in our times, I still remember patients used to regard the doctors as God or things like that, you know, which is, I don't believe them, but then they are. But now it comes to different. Now they think the doctors are money suckers. They just want to make money and like that. All sorts of degrading things there. So all the things we have to counteract by telling us whatever we have been doing to the general people, so that they also feel that we are part of the society which is trying to help us. Well, we have been hearing about jail without bail. A lot of things have been in the last few years, but nothing has happened. It has passed as a bill, but nothing has come out of that. It just means that now SSN has to collaborate and work together with other like-minded organizations like the Department of Association and other things to work for the better future of our profession, so that I think, especially because we should take the lead, the society should take the lead in this activity. Well, in the end, I think I would like to share with you a new syndrome which is affecting the senior citizens in Nepal. We call it empty nest syndrome. It's not only affecting the senior citizens here in Nepal, in Kathmandu or the cities, but also in different villages of the country also. Only if you find the old people in the house and their younger children and their grandchildren are no more there. This personally I am definitely feeling for the last few years, but I really hope and pray that you younger colleagues will not have to face that emptiness syndrome. I don't have to tell you more about emptiness syndrome, which obviously everybody is for it these days. Thank you very much.
As we all know, surgeons are very careful observer and also very creative, like we see today. Now to proceed further, we would like to request the General Secretary of Surgical Society of Nepal, Dr. Bikal Ghimre, to present the annual report.
Guest of honors, past presidents, respected advisors, and all the international and national delegates. On behalf of the organizing committee, we would like to cordially welcome you to this 15th International Conference of the Society of Surgeons of Nepal. We started our tenure at the hardest of times when COVID was still a threat. We celebrated the Nepali New Year with a CME at the Soti Hotel, and we had Dr. Pratik Man Singh Gurung presenting along with Dr. Young Rok Choi from the SNUH, South Korea, and we had new members being welcomed and felicitation of our senior members for their contribution to the society. So over the years, I would like to thank all the surgical departments of the medical colleges and hospitals in Kathmandu who continued the monthly clinical meetings and the ever-increasing participation. Presently, we have 5 regional chapters. Eastern Viratnagar led by Dr. Rohit Prasad Yadav, Madhya Pradesh chapter led by Dr. K.N. Singh, Chitwan chapter led by Dr. Binay Thakur, Gandhari chapter led by Dr. Bhojraj Neopane, and Lumini chapter by Dr. Baburam Paudel. I would like to thank them for their effort in taking the society further ahead. The regional chapters of SSN has had numerous clinical meetings, and most of them were accessible to all through Zoom, and I thank them for the initiative. So on the 22nd of December, Department of East Medical College, on collaboration with the Society of Surgeons of Nepal, successfully conducted the hands-on cadaveric workshop with the theme helping learn surgery in scientific and safest way and applied anatomical annotation. And it was followed by the same program and at Dhuli Hospital. So with the support of the Lumini chapter, the Society of Surgeons of Nepal successfully organized the 13th National Conference on 11th and 12th November at Lumini, Bhairava. We had more than 300 delegates from all over the country participating at the event. There were more than 70 associate members from numerous medical colleges with active participation on 3 papers. We had participation from we had a few international guests as well, and it was a wonderful event. And I thank the Lumini branch for taking this initiative, and especially Dr. Santosh Shah and Dr. Raj Podal for the initiative and making this program successful. And with the support of SSN, laparoscopic immunohernia simulation training was conducted by Dr. At NAMS in collaboration with Hokkaido University Clinical Simulation Center at NAMS, and Dr. Anip Joshi along with Dr. Sasim Paudel, Dr. Kurashima and Dr. Koto Kiriyama conducted the program, and many surgeons and residents participated, and I thank them for that as well. So the Association of Bilingual SS Surgeons of India recently had the 17th International Conference, ISSNCON 2022, on 18 November at Guwahati. We had our President, Professor Sunil Kumar Sharma, had been invited, and he was conferred honorary fellowship of pharmacy, and he was felicited as guest of honor. It was indeed a very honorable moment for us, and I thank Amasi for the initiative. And at the time we had meetings with Professor Juginder Sor Kambam. He was the incumbent president, along with President-elect Dr. C.J. Verghese, and we had discussions on further collaboration of SSN and Amasi in the coming days ahead. So Nepali New Year celebration with monthly CME was held under the auspices of the Department of Surgical Oncology, Bhaktapur Cancer Hospital, and I extend a hearty thanks to Dr. Utsav Mansreshta and the department for the initiative. The 52nd Sri Lankan Surgical Congress, organized by the College of Surgeons, was successfully conducted on 14th to 16th of September, and Professor Sunil Kumar Sharma Dakal was conferred honorary fellowship during the event. During the event, presidency of the SAC Surgical Care Society was handed over to Professor Sunil Kumar Sharma and by the current president, Professor Dr. M. Lamavansa. On October 6, 2023, KMC Department of Surgery hosted Dr. William R. Jargan for the discourse on the frontiers in SBB oncology, and it was a very fruitful event with a lot of young doctor surgeons participating, and I thank them for the initiative. Society of Surgeons of Nepal successfully conducted the AMASI skill course and fellowship exam held on September 29th. It was lots of surgeons and gynecologists participated. It was held at the Nepalese Army Institute of Health Sciences, and this was the 97th skill course. And it was the focus was more on basics as well as advanced laparoscopy. Altogether, there were 104 participants, which included 28 gynecologists, and there were 3 participants from India. And it was, though it was a tiring 3-day course, all the participants enjoyed it, and I thank AMASI for the initiative. We had the president of AMASI, along Professor Dr. C.J. Varghese, along with the president-elect, Dr. Kalpesh Jani, Dr. Tamnath Chaudhary, and three other members of AMASI as faculties during the event. And I thank the local faculties, Dr. Padamraj Panta, president-elect of the NISOG, Dr. Mukunda Raj Joshi, president of the Nepalese Association of Surgical Gastroenterology, Dr. Apurva Sharma, Dr. Rahul Pathak, as well as Dr. Ganesh Dangal for the initiative. So, ISSNCON 2023 had the international conference at Raipur, Chhattisgarh. There were more than 1,000 participants from all of the places, and in that we had a SARC session, and in the SARC session, SSN along with members from Bangladesh and Pakistan presented, and it was a very interactive event. I would like to mention that finally JSSN, Dr. Tankar has been working hard along with Dr. Manish and the team to take JSSN ahead, and Dr. Anip as well, and JSSN has received 2 stars of the JPPS framework, and it is a very good motivational opportunity for us, and I hope we go further ahead and have the permanent index as well. So SSN has been conducting basic skill courses and basic lab skill courses, and on 2nd of March it was conducted at East Medical College led by Dr. Rupesh Mukhi and his team, and recently the society has procured few laparoscopic trainers, and we are also in the process of having some trainers for advanced surgery, endoscopy and others as well. So the society has conducted a webinar series for the last 1 year, and we had around 24 webinars, and I would like to thank all the faculties who took time off their busy schedule, and all the residents and doctors that participated in the webinars. And we will be continuing this series further on. And I would like to thank AWR for the pre-conference workshop, and this year we had around 148 members incorporated into the society. I welcome all the new members, and I look forward to working with them in the future so that we can have more interaction in the society as well. So we are in the process of, we had this skill indoor trainers, and then we are also preparing others for the youngsters to train. And I would like to offer my condolences to all the members that passed away, and may their soul rest in peace. And lastly, I would like to thank the seniors that have taken so much effort over the years and contributed to the society so that we could stand today here amongst you and have this program, and all our past presidents who have taken all the efforts and taken this society to this height. And I hope that in the future the society has passed through many difficult times, and as we move ahead to the future, we hope that the younger executive committee will take it to further heights and further achievements. Thank you.
Thank you, Doctor. Now may I request Dr. Pranil Rai to please come forward for the scientific report.
Respected President, Organizing Chair of the Conference, Professor Sunil Kumar Sharma, Honorable Chief Guests, Professor S.K. Bhattacharya and Professor Dali, President-elect Dr. Romeo, Organizing Secretary Dr. Bikal, Chief Editor Dr. Tanka, eminent personalities, dear delegates, friends, ladies and gentlemen, a very good evening to everyone. It has indeed been a moment of pride for us to conduct this conference for the society. This has come after a long time. It has been 5 years since the last conference. This conference is usually a biennial event, but because of the COVID pandemic, we were not able to do it last time. So finally this year we were able to come up with this international conference, and then I think the next year we'll be having a SARC conference, and then again an international conference 2 years down the lane. Yesterday we had a very wonderful workshop, pre-conference, which was on AWR. It was in association with the AWR surgeons community. And those of us, the delegates who attended the conference, I think had a fruitful time. And in these 2 days conference, we have 4 orations. 2 of them we already had it today. We have around 50 guest lectures and 81 free papers from all the eminent speakers from abroad and from within our country. And we have a debate and a panel discussion, and we have 2 sessions of video presentations. The one finished today, and we have it tomorrow again. So the theme of the surgery, this time the theme of the conference has been global surgery. And with this ever-changing, the evolution of medicine, the advancement of surgery, and this is a very good theme for this year. So, regarding our future plans, the conference is going to be on a regular basis, and I think today has been a very academic session, the first day, and tomorrow also I believe it will be the same. We'll be continuing till evening tomorrow, unlike in the previous years where we used to finish it off by afternoon. So tomorrow also will be till evening, and I hope all the delegates will fully enjoy the academic feast. And before I end, I would like to thank all members of the scientific team, the scientific committee. They have worked really hard, and they've been working for the last week. I've been asking them to work very hard in the night, in the evening, anytime, and then they've never said no. And our colleagues from the executive committee, and I take this opportunity to thank you all for trying to make this success. So with this, I would like to end here because I don't want to make it too long. Best wishes to everyone. Thank you.
Fellowship of Surgical Society of Nepal and membership of Surgical Society of Nepal, we'd like to request Professor Dr. Abdul Majid Chaudhary to come up on the stage, and I'd like to request Dr. Pranil Rai.
Professor Dr. Abdul Majid Chaudhary is a distinguished figure in the realms of surgery, education and administration, celebrated for his unwavering professionalism and academic prowess. As the principal of Lahore Medical and Dental College since May 2010, he carries a wealth of experience, having previously served as the principal at Fatima Jinnah Medical College for a notable 3 years tenure. Born on May 1st, 1950, Dr. Chaudhary earned his MBBS in 1973 followed by FRCS from Edinburgh and Glasgow in 1978, FCPS in 2005, and MHPE, Masters in Medical Education from Holland in 2008. Notably, he was awarded the Fellowship of the College of Surgeons of Sri Lanka in 2009. Demonstrating a commitment to surgical excellence, Dr. Chaudhary has dedicated himself to achieving practical, sustainable, and affordable surgical solutions for prevalent healthcare challenges. His influence extends globally, with a substantial number of his trainees now contributing in various capacities within and outside of Pakistan. Serving as the president of the SARC Surgical Care Society, he plays a pivotal role in fostering collaboration among the surgical fraternity of the SARC region. Dr. Chaudhary's impactful career includes serving as the chairman of the Department of Surgery at King Edward Medical College and University for over a decade. During his tenure, he initiated the official journal of King Edward Medical College, the Annals of King Edward Medical College, which gained recognition from the Pakistan Medical and Dental Council and was indexed in IMMER Index Medicus. A trailblazer in medical education in Punjab, Dr. Chaudhary organized 2 international conferences on medical education and chairs the National Curriculum Committee of the Pakistan Medical and Dental Council. Beyond his administrative roles, he contributes significantly to postgraduate medical education as an examiner for various universities and advisor to international bodies such as the Royal College of Surgeons of Glasgow, UK, and the Punjab Public Service Commission. His scholarly pursuits are evident in his authorship of over 70 research papers and textbooks, including Essentials of Surgery for Dental Students and Handbook of Clinical Skills, showcasing his enduring impact on the medical community and education landscape. Thank you.
Like I said previously as well, Paul Medusa, he's a towering personality who needs no introduction. So, fondly regarded as Chief Sir, he's an extraordinary personality, not just because of his accomplishments, but the journey that he went through. As a renowned gastrosurgeon, he has significantly contributed to the field of medicine. His surgical skills and innovative techniques have not only benefited his patients directly, but also influenced the broader medical community. So what is inspiring about Apollo Medusa is that he has made so much innovations in surgical technologies, especially in laparoscopy, that it has reached like common people, and it is very contextual in our country and in our subcontinent as well. His list of accomplishment is extensive and reflects his dedication to the betterment of healthcare. There are numerous techniques that he has devised in laparoscopy and numerous awards that he has received. So, it is an honor to have Paul Medusa here amongst us, and I thank him for accepting our invitation and coming to Kathmandu at this moment. Thank you, sir. respected President of the Society of Surgeons of Nepal, Honorable Chief Guest of Honor, executives, dignitaries on the dais, guests from abroad, national and international delegates, ladies and gentlemen, namaste and good evening. So it's a matter of great honor to stand before all of this august gathering to introduce Dr. Christopher Martin Pike, whom I had the privilege of knowing during my stay in Adelaide, Australia. Dr. Christopher Martin Pike is Professor of Surgery at the University of Queensland and Director of Surgical Services at Mater Health, Brisbane, Australia. His academic accomplishments include his completion of general surgery training in Australia, followed by his fellowships in breast surgery and endocrine surgery in Nottingham, United Kingdom, followed by his further training fellowships in Mayo Clinic in Minnesota, United States. He further did his Doctor of Philosophy on breast cancer risk quantification, and he has numerous papers in national and international journals to his credit. And he's also a leader in healthcare in Australia, which is characterized by his former presidency of Breast Surge ANZ, that is the Breast Surgical Society of Australia and New Zealand. And he is current chair of professional standards with the Royal Australasian College of Surgeons. He has also been previously chair of the Training Board of General Surgeons of Royal Australasian College of Surgeons, and then he has also chaired the Court of Examiners and also served as Vice President of the Royal Australasian College of Surgeons. Dr. Christopher Martin Pike has honorary fellowships from Association of Surgeons of India and also the Royal College of Surgeons of Edinburgh. Professor Dr. Christopher Martin Pike has been very instrumental and has shown his great interest and passion in supporting, in further advancing the standard of surgical care, surgical training programs, and surgical research in our country. And that is where I came along with him with a vision and a similar goal which we shared together. So ladies and gentlemen, it's a matter of great honor to present you before you Professor Dr. Christopher Martin Pike for Honorary Fellowship of Society of Surgeons of Nepal. Professor Martin.
Now we would like to request Professor Dr. Rupesh Rukia. Now we would like to request Professor Dr. Rupesh. So good evening, ladies and gentlemen. It's my honor and privilege to introduce in front of this August gathering, Dr. Pinto. Dr. Narendra Pinto is a distinguished figure in the medical field, renowned for his exceptional contribution as a senior orthopedic and trauma surgeon, lecturer and advocate for disability care in Sri Lanka and beyond. Dr. Pinto earned his MBBS and MS Sri Lanka before furthering his expertise with honors like FC, SSL Honours, FRCS England, FRCS Edinburgh, FC PSP Honorary Pakistan, and FASI Honorary India. His commitment to excellence in surgery has been evident throughout his career. Dr. Pinto has been a cornerstone at the Dr. Neville Fernando Teaching Hospital, Malawi, and the South Asian Institute of Technology and Medicine. His dedication extends beyond surgery, encompassing teaching and mentoring the next generations of medical professionals. A testament to his commitment to the holistic disability care, Dr. Pinto founded Sri Lanka Spinal Cord Network. He incorporated all stakeholders under the auspices of Asian Spinal Cord Network and SARC Surgical Care Society, furthering collaboration in the field. Dr. Pinto served as its president from 2009 to 2011. As a past president of Sri Lanka Orthopedic Association, his leadership from 2009 to 2010 saw the initiation of annual scientific sessions, contributing to the academic growth of orthopedics in Sri Lanka. Dr. Pinto's impact on national hospitals spanned from 2003 to 2015, where he served as chief surgeon of accident service and later as a senior orthopedic and trauma surgeon. In 2018, Dr. Pinto was bestowed with this prestigious award in India, recognizing his outstanding contribution to the field of surgery. Dr. Pinto holds honorary fellowship from esteemed institutions including College of Surgeons of Sri Lanka, College of Physicians and Surgeons of Pakistan, Association of Surgeons of India, and Royal College of Surgeons of Edinburgh. Dr. Pinto's research interests span spinal trauma, spinal cord injuries and rehabilitations, disability care, arthroplasty, and limb-saving resection for the bone tumors. His commitment to advancing medical knowledge is further reflected in his role as an examiner in MRCS England, Royal College of Surgeons of England. In various facets of his career, Dr. Pinto has exemplified unwavering dedications to healing education and advocacy, leaving indelible mark on the medical community in Sri Lanka and borders of the South region. His legacy as compassionate healer and visionary leader continues to inspire a generation of medical professionals. Ladies and gentlemen, it's my honor to confer him from the Society of Surgeons and President of Society of Surgeons of Nepal. Please welcome Professor
To honor our fellow delegate, Professor Dr. Kajunari Dhanabe.
Ladies and gentlemen, it gives me an immense pleasure to introduce Professor Kazunari Dhanabe. He is currently the Director of Robotic Surgery and Organ Transplant Center in Sonan Kamakura Hospital, Japan. Previously, he was the Chairman and Director of the Tokyo Women's Medical University Hospital. Dr. Dhanabe has earned his MD degree from Kyushu University at Fukuoka, Japan, and completed his urology residency and transplant clinical fellowship at Tokyo Women's Medical University Hospital. He also has a research fellowship in uro-oncology from Cleveland Clinic Foundation in Ohio. Dr. Dhanabe has served for more than 30 years as a urologist and transplant surgeon and has performed more than 2,000 cases of living kidney transplantation. He is also one of the pioneers of ABO-incompatible kidney transplantation and robotic surgery in the world. He has authored more than 300 peer-reviewed publications and has more than 400 papers both in Japanese and English. His research interest includes renal and pediatric transplant and immunology. Currently, he also serves as the Deputy Editor of Transplantation Journal and is an executive member of the Japanese Society of Transplantation and the Society of Clinical Kidney Transplantation. Thank you.
special honorable fellow delegates for being us with here tonight. It is a very pleasing moment for all of us, and thank you that you have graced the stage at this event with your presence.
Now, on behalf of all the respected fellow delegates, I would like to request Dr. Narendra Pinto, the Director General of SARC Surgical Society at headquarters in Colombo, to have his few words.
I extend my sincere gratitude for the tremendous honor conferred upon me by way of an honorary fellowship from your esteemed Society of Surgeons of Nepal, the apex body of the surgical fraternity in Nepal. Please allow me to convey warm greetings on behalf of Sri Lanka, representing the College of Surgeons of Sri Lanka and the headquarters of the SARC Surgical Care Society. Nepal has consistently demonstrated active engagement within the SARC Surgical Care Society, achieving many significant milestones under the leadership of my friend, Professor Rakesh Verma. During his presidency from 2012 to 2014, the camaraderie and the fellowship shared with the surgical community in Nepal had been, this was dating back about almost a decade ago, have been a source of great joy and inspiration. Reflecting on my encounters with Professor Sunil, when we first met in Lahore, Pakistan, along with Professor Abdul Majid Chowdhury, I could immediately spot the exemplary leadership qualities by Professor Sunil Sharma and his dynamism. The unforeseen regional challenges have expedited Nepal's turn in the line of presidency of the SARC Surgical Care Society. And fortunately for us, Professor Sunil was there to take up the challenge. We all are confident that he will take this organization to greater heights, fostering international relations to serve the people, the needy people of this vast region, representing about almost 25% of the world population. Thank you very much for the opportunity given to me to address this August gathering. And furthermore, I take this opportunity to present a special plaque to the newly appointed President of the SARC Surgical Care Society, Professor Sunil Kumar Sharma. This memento is awarded by the SARC Surgical Care Society headquarters based in the capital city of Sri Lanka, along with the College of Surgeons of Sri Lanka. With your permission, may I invite the following dignitaries to the stage. Dr. Ranjit Ellavala, past President of the College of Surgeons of Sri Lanka. Dr. Dulanta De Silva, Secretary General of the SARC Surgical Care Society. Professor Abdul Majid Chowdhury, past President of the SARC Surgical Care Society. Professor Rakesh Verma, past President of the SARC Surgical Care Society. Professor C. Palanavelu, past President of the ASI, representing India, one of the SARC, great members of the SARC. Professor Iqbal from Bangladesh. You see, yes. Representing Bangladesh. Last, there are no representatives from Bhutan and Maldives. Last but not least, Australia and Japan have been given the observer status for the SARC organization. So we have two great personalities. So may I invite Professor Chris Pike and Professor Tanabe from Japan to award this plaque to Professor Sunil Kumar Sharma. This is to mark his induction as the President of the South Surgical Care Society.
Surgical Society of Nepal, we would like to request Professor Dr. Achyut Prasad Sarma to come up.
Good evening, ladies and gentlemen. It is my honor to introduce tonight's one of the recipients of SSN Lifetime Achievement Award, Professor Brigadier General retired Dr. Achyut Prasad Sharma. Born in Tansen, Palpa in 9 June 1951, Professor Sharma completed his initial schooling from Padma High School in Tansen. He did his MD from Rostov-on-Don State Medical Institute in 1978. After returning, he joined the Nepal Army Medical Corps as a medical officer at Trichandra Military Hospital in December 2078. 1978, I'm sorry. Brigadier General Sharma served in different remote postings during his tenure as a medical officer. Among them, he was the sole doctor at the first Royal Nepalese Army mountaineering expedition to Mount Tilicho, Kaisan, Mustang and Manal. For his surgical education, he went to UK and was awarded the fellowship of Royal College of Surgeons of Edinburgh in November 1991. Subsequently, he completed his neurosurgical training from Brooke General Hospital in London and Manningham Army Medical Center, Washington State, US in 1995. Professor Sharma has remained as one of the pillars of surgery department at the Army Hospital. He was the head of department from 1995 to 2000, clinical registrar of the hospital from 2000 to 2006, and commandant of Sri Birendra Hospital from 2007 to 2009, after which he retired from active medical service. But he returned to his roots and joined Lumini Medical College, Palpa, as the hospital director from February 2009 to December 2014. However, after inception of the Nepalese Army's Institute of Medical Health Sciences, College of Medicine, he served as professor of surgery at the institute from 2015 to 2023. He retired recently and continues to practice as consultant neurosurgeon at Medicare Hospital. His postgraduate surgical teaching career started with his association with NAMS, where he was professor of surgery from 2005. Subsequently, he continued undergraduate and postgraduate teaching in NIHS from 2015. His students and residents always remember him as a simple, straightforward, dedicated teacher, a surgeon of high principles. Being one of the first batch of residents of NAMS to study under him, I still remember scampering in the cold winter morning to reach the morning rounds by 7 a.m. in vain attempt to reach before him. His patients still remember him as a compassionate clinician, very approachable and willing to listen to all their ailments, very humble, yet decisive in his treatment. In the army, he is remembered as a highly dedicated and highly disciplined officer, a gifted surgeon, and a true leader. He has never shied away from his responsibilities of a general surgeon in spite of being a neurosurgeon, a true army surgeon able to work in all adverse conditions. The SSN will always remember his punctuality and active participation in all of the clinical meets and conferences. Personally, sir, I will remember you, sir, for your high principles that you have unflinchingly maintained throughout your life, a perfect role model surgeon for all junior surgeons to try to emulate. For all the contributions you have made to the upliftment of the surgical community in the country, the Society of Surgeons Nepal has decided to confer the Lifetime Achievement Award to Professor Brigadier General Retired Dr. Achut Prasad Sharma.
Thank you so much. Thank you for contributing to our society and our country. Now to proceed further, we'd like to request Dr. Sunil Shrestha to bring in the stage our another.
Good evening, everybody. It is my privilege to introduce Professor C.L. Bhattachan, who has always been my guru, my mentor, who taught me the way of surgery he has done and the way today I am. So he was born on 15th August 1943 to the late parents, Mr. Bharatlal Bhattachan and Mrs. Dhanukumari Bhattachan in Galkut village of Baglung district of Nepal. Is Professor Chitralal Bhattachan. He had his primary education in his hometown and completed his matriculation from Juddhabhai Public High School, Chhatrapati, and intermediate in science from Trichandra College in Kathmandu. After completion of his MBBS from R.G. Kar Medical College, Kolkata, he joined Bir Hospital as a medical officer. He wanted to serve in the remote part of the country and was therefore transferred to Mustang Health Center in Johnson from 1971 to 1975. During this period, he worked continuously and successfully to upgrade the health center into a small district hospital. He had a strong desire to have this hospital inaugurated by the late King Virendra during the royal visit, but it was inaugurated by then Prime Minister Nagendra Prasad Rizal under the instruction of Their Majesty. His work has been appreciated by honoring him with Gorkha Dachin Bhav Medal with 2 additional grades and promotion to senior medical officers. In 1974, he was selected for fellowship in surgery under Colombo Plan Scheme scholarship scheme in Royal College of Edinburgh, United Kingdom, and traveled to England where he was trained in different hospitals in general surgery. After completion of his fellowship, he came back to Nepal and worked in Bir Hospital for some time as a surgical registrar. He then went back to England to pursue advanced surgical training in gastrointestinal and hepatopancreatobiliary surgery. During his stay in England, he was offered a job as consultant surgeon from King Fahd University Hospital in Saudi Arabia and served there in various positions like consultant surgeons, deputy head of surgery, member secretary of postgraduate training in FRCS program, and also examiner for FRCS and Arab board. He then worked as a consultant general surgeon in Cambridge University for the whole of 1996, and during this tenure, he achieved Fellow of American College of Surgery. Later, he was appointed as senior consultant in Nepal Medical College in the year 1998 and after a few months, he was appointed as Professor of Surgery by Kathmandu University. From 1999 to 2017, he served the Department of Surgery as head of department. He retired from Nepal Medical College in the year 2020. He has been an examiner for undergraduate, postgraduate, fellowship exams at home and abroad for almost 3 decades of his surgical career. He has attended and presented various scientific papers at home and abroad. He has traveled all over the world. Also, he has published 60 to 70 scientific articles in national and international journals. He has published a book on an aids to housemen and interns, and also contributed a chapter on pancreatic diseases in the book Principle of Surgery by the late Professor A. Kishan. Professor Bhattachan had an opportunity to meet and interact with renowned professors like Nobel laureate Joseph E. Murray, who has performed first dizygotic twin renal transplantation in the year 1954. Also Professor Henry Bismuth, renowned HPV surgeon, and many more. He has also been the past president of Surgical Society of Nepal and advisor to Nepalese Association of Surgical Gastroenterology. He has recently been completed 50 years of togetherness with Mrs. Durgesh Nandini Bhattachan, and he is a loving father to his son and daughter. I wish him the very best in the upcoming phases of his life with good health and prosperity. Thank you.
Bringing the stage, Professor Dr. Mahesh Kakurel.
So good evening, ladies and gentlemen. It's an honor for me to introduce Professor Mahesh Kakurel. As a pillar of surgical community and a role model of excellence in Nepal's medical field, Professor Dr. Mahesh Kakurel has been crucial in determining the direction of surgical education and practices in our nations. He was head of Department of Surgery at Tribhuvan University Teaching Hospital, Institute of Medicine, Kathmandu. Born in Kichapokari, Kathmandu, he attended Lainchar, Shanti Vidyagriha and Trichandra College for his SLC and intermediate education. He then pursued an MBBS at Amritsar Medical College as part of Colombo Plan. In 1981, he received his FRCS from Royal College of Surgeons, Edinburgh, after pursuing his studies in Japan with a specialization in surgical gastroenterology. As serving as past president of Society of Surgeons of Nepal, vice president of Gastroenterological Society of Nepal, and executive member of Nepalese Liver Foundation, Dr. Kakurel has been instrumental in promoting cooperation, sharing of knowledge, and progress in these vital areas of medicine. The fact that Dr. Kakurel is a member of Institute of Medicine's postgraduate committee further demonstrates his dedication to education. He is among the nation's pioneers in the field of laparoscopic surgery. He has won numerous honors in recognition of his extraordinary effort, including Subha Rajya Risik Padak, Durgam Stan Seva Padak, and Shiksha Puraskar from Tribhuvan University in 1996. He is recognized by extraordinary influence he has had on surgical education, healthcare organization, and patient care in Nepal. Ladies and gentlemen, it's our honor to present him the Lifetime Achievement Award 2023 from Society of Surgeons of Nepal. Thank you, sir.
transplant in CMCTH, a preliminary experience. Can you please come forward? And I request Dr. Romeo to please provide him the award. Dr. Vishal Acharya, Hospital. Dr. Uttam, would you please come up on stage? Any representative or Dr. Uttam? I request Dr. Romeo to provide him the award. Dear volunteers, can you please bring in the awards? Can you please bring in the certificate for the Best Young Resident Award? Next up, we have Best Poster Award of Surgery in a Tertiary Care Hospital in Nepal. Dr. Khagendra Oja, may we please request you on stage? To all of our award winners, Best Young Surgeon, Best Young Resident, Best Poster Award, we wish you for the excellence in the future.
This program is successful because of the Executive Committee, of course, all of you respected delegates, our fellows and international guests, but along with that, we have the sponsors without whom we could not do this great program. I'd like to mention the name of all the sponsors, and I'd like a couple of them to come on behalf of everyone because we're short of time. So I'd like to thank DJPL, Max Healthcare, J&J, B. Brown, Santosh Mazi from East West Concern, Asian, ATK, Golden, Aristo Pharma, Dr. Yogan, Dr. Reddy, Allen Electronic, Global Health Net, Kara, Alchem, Microlab, Siddharth Pharma, Greenhouse Solas, Vision Health, Sun Pharma, Lubin Foundation, and many more. I would like to request the representative and would like to thank all the sponsors, and if I have missed some of the names, we're very thankful to you and would like you to sponsor us in coming days as well. Now, as I said, we are going to announce the new executive of the Surgical Society of Nepal. For that, I would like to request the Election Commissioner of Surgical Society of Nepal, Professor Manohar Lal Shrestha, to come up on the stage and announce the new executive committee. And also I would like to request the audience to
the executive committee for trusting me and my team, Sunil Shrestha, Professor Sunil Shrestha, and Dr. Niranjan Palikhe for appointing as a Chief Commissioner of Election and Commissioner of Election for Society of Surgeons in Nepal, election for next January. I think actually the trend this time we had more diplomatic or democratic because we had election for 5 members. Otherwise, the executive committee, the president and the team was nominated or elected unanimously except the members. I think this democratic sort everybody has got right to. Otherwise, in olden time or in previously, we used to have all nominated or volunteer for this post. Before I announce the name, I must thank the Region Executive and congratulate them for wonderful tenure and having such a wonderful conference also. So, please put your hands together to Romeo Kansakar, who is elected as a president. I think I like the senior citizens, those that are present in the dais, to give the certificate rather than me. President-elect, Dr. Robin Joshi. Oh. Vice President, Bikal Gemari. General Secretary, Sen Rupaketi. Treasurer, very popular treasurer, Smita Pradhan. Good. Joint Treasurer, Dr. Rosen Giveri. Member, Rosen Rupesh Mukhia. Member, Kanka Prasad Bora. Member, Susil Dungel. Member, Bikal Givri. Sorry, Pranal Roy. Okay, and Joint Secretary Anil Joshi. And last, the member is Utsabman Shrestha. So, thank you, sir. Congratulations to all the new executives and wish them have a good and successful tenure. Thank you very much.
Before I hand over the medal, there's a small announcement I'd like to make. Dr. Abdul Qadir Chaudhary has worked very hard on the textbook of surgery by SAARC countries. So all of us from SAARC region have contributed to that book. I've contributed, so has Sri Lanka, India, Bangladesh, and Pakistan, even Afghanistan. So I will encourage all of us to look into that book, and it's getting released very soon by Elsevier. And please give your feedback so that our future editions will be better. Now, who better to hand over the medallion to than my friend Romeo? There's a connection between Romeo and me that a lot of you don't know about. We share the same birthday, though it is 11 years apart. So Romeo Kansakar, I'm sure, is going to be a very enabling president and is going to take this society higher, and I wish him all the best. However, he just gets it for a minute.
Congratulations, Dr. Romeo Kansakar. A medallion is a reminder of what you have overcome and what is further we need to do. and we congratulate you again. Now for vote of thanks, I'd again like to call Dr. Romeo on the podium for vote of thanks.
President, Society of Surgeons of Nepal, our dignitaries on our dais, our seniors, my colleagues, ladies and gentlemen. So first of all, I would like to thank all the international delegates who have come all the way from India, Sri Lanka, Bangladesh, Japan and Australia to teach us something. So thank you very much to all the foreign delegates. I would like to thank our seniors, our patrons, without whose blessings this society would not have gone abroad. So thank you very much, our seniors. So another thing is, like, we have, without the delegates from national and international delegates, especially all the delegates from outside of Kathmandu, I'd like to thank you all for coming here. Without your support, this conference would not have been a success. I would also like to thank AWR for their cooperation for the pre-conference workshop, and BNB Hospital, who gave us the venue for the pre-conference workshop. I would also like to thank the executive committee of the Society of Surgeons of Nepal, especially Dr. Bikal, Dr. Tankar, Dr. Pranil, Dr. Sumita, Dr. Anip, Dr. Sushil, Dr. Manish, and Dr. Abhishek, and Dr. Rupesh. So if I missed anyone, and please forgive me. And also our office secretary, Mr. Keshav, who has been working day and night to helping us for this conference. And another is, I would like to thank all the volunteers. They have been working day and night to make this conference a success. So we have a band after this. The army band has played right now, and we have the Kutumba, which is a very good musical band from Nepal. So they'll be playing for us after this program. So I would like to thank them also for their contribution. Another is, I would also like to thank all the sponsors. Without their help, we would not have made this program a success. So thank you all the sponsors, and we should also give them a big hand. Thank you very much. So last but not the least, I've been given this burden of the President of Society of Surgeons of Nepal. So I think we have to take, I will be living up to your expectations. I need support from all the national and international delegates to collaborate with you all, from the seniors, your blessings, and from the juniors, your support. So thank you very much. I think with this, we'll take SSN to greater heights. Thank you very much. Long live SSN.
The Society of Nepal for letting us this opportunity, and I would like to thank you all who are present here, all the respected delegates from different countries, the Lifetime Membership Award winners. I could also see the first President of Surgical Society of Nepal, the past President of Nepal, the President of Nepal Medical Student and different societies, and also the head of department of different medical colleges. I would like to thank you all, and without further ado, I would like to tell you that the formal program is over, but we have the performance of Kutumba Band and also the amazing dinner. And with this, I would like to thank you all. If we have done any mistake, please forgive us. We'd like to learn more from you all, and thank you once again.
Right, and can you all say hey? Louder and shorter, hey! Enough. Right, I just got a... Kanchi, hey Kanchi.
होइन भनी
Thank you.
नाच्ने नै हो त होइन
Thank you.
क्वेश्चन लेखिदिनु न त्यसै हजुर आज we had a very honor यहाँ चाहिँ के भन्छ भने हामी किसिमकोलाई चाहिँ we know how hard you guys work है अनि त्यो कुरा चाहिँ कहिले थाहा हुन्छ भन्दाखेरि
Kutumba. They make us proud, not only in Nepal, but throughout the world. They represent us, our culture, our music, and us, the feeling of the Nepali people. So for this and the generosity of them having given us such a beautiful concert, we would like to give them this certificate of great appreciation to Kutumba by the Society of Surgeons. ताली पुगेन यसपछि डिनर प्रोग्राम पनि